Hello and welcome. It's Dr. Anil Joshi welcomes you to my series that is called Learn Radiology with Dr. Anil Joshi. We're going to see today basics of sonography, that is a color Doppler applied for the carotid. So today's topic is the Carotid Doppler Sonography, and the lecture is going to be given by Dr. Anil Joshi. At the onset, I want to do some disclosures. This is a education series meant for the radiology aspiring students and also those who are interested in knowing the color Doppler techniques. It is not meant for common people, neither it is meant for any medical legal purpose. No references should be given from this topic anywhere. This is just for the information and not meant for the references or for medical legal purposes. At the onset, we disclaim that certain material has been downloaded from the net, which is free and without royalty. Though most of the material is our own, some we do agree has come from the departmental presentation work, which is from years. Now it is the introduction and the technical aspects of the procedure that is called as the carotid Doppler. Now, carotid Doppler introduction. It is an investigation of choice in evaluating atherosclerosis of the carotid artery. Its ability to measure the intima media thickness makes it ideal for assessment of a biomarker for atherosclerosis. It is not only identified it not only identifies plaques but also gives idea about its characteristics and morphology, and therefore useful for evaluation of stroke. It's one of the main indication why the carotid Dopplers are performed. Now the carotid artery anatomy is essential to be known before we go to the technique. The right and the left common carotid arteries ascends from the neck, that is posterior lateral to the thyroid gland, and lie deep to the jugular vein and sternocleidomastoid muscles. The common carotid arteries have different proximal, the right origin beginning at the bifurcation of the innominate artery into the common carotid and a subclavian vein. So that is as far as right common carotid artery is concerned. The left common carotid artery usually originates directly from the aortic arch. However, it arises from the brachiocephalic trunk, and common carotid artery usually has the common carotid arteries has usually no branches in the cervical region, so they do not branch in cervical region. Occasionally, however, it might give of superior thyroid artery, vertebral artery, and ascending pharyngeal artery, and occipital or inferior thyroid arteries. These are the occasional branches. The carotid bifurcation, at the carotid bifurcation, the common carotid artery divides into external carotid artery and internal carotid artery at the bifurcation. The internal carotid artery usually has no branching vessels in the neck. The external carotid artery, which supplies the facial musculature, has multiple branches in the neck. The internal carotid artery has it, the internal carotid artery may demonstrate an ampullary origin of the mild dilatation just beyond its origin. Now let's come to the radiology. Indication for carotid ultrasound. Evaluation of patients with hemiparesis or neurogenic symptoms including stroke, transient ischemic attack are the main indication for common carotid artery Doppler evaluation. Evaluation of patient with a carotid bruit, that is a clinically indicated. Evaluation of pulsatile neck masses. Evaluation of patients scheduled for major cardiovascular surgeries and following radiation therapy of the neck. These are the indication for carotid artery examination. Evaluation of patients with unexplained neurological symptoms are additional. Follow-up of patients after carotid stenting or knowing carotid revascularization, monitoring during vascular surgery are due to add. Evaluation of suspected subclavian steal syndrome, evaluation of potential source of retinal emboli, and follow-up cases of carotid dissection. Now, carotid arterial bruit. It's a clinical manifestation, and often the clinician sees them in all the cases suspected to have intracranial pathologies. It is important to know whether the carotid artery indicate the presence of a significant lesion. So that is one of the indication of carotid Doppler. The, the absence of carotid artery will preclude the presence of significant lesion, and will the presence of carotid artery will change further investigation and disproportionate. Now, technique of carotid Doppler. Please note, carotid Doppler is color-coded velocimetric information technology. Color Doppler is a good tool for visualization of blood flow in the vessels by visualizing change in the velocity. Therefore, we can detect stenotic segments. When we are doing all these things, a proper color Doppler image needs to be obtained to give an appropriate interpretation. A linear probe with adequate acoustic angle to generate a grayscale image. Secondarily, the sonic beam has to be perpendicular to the skin. These are the few prerequisites to obtain a proper color Doppler image. To obtain proper velocity information from color Doppler, the angle should be between 30 to 60 degrees. Now, color velocity scale. It sets below the mean velocity of the blood flow. Aliasing through the vessel lumen will occur. Now, if we set it wrongly, there will be aliasing. Aliasing may disappear, resulting in a missed stenosis. So, proper setting is essential. If the setting is higher, then the velocity of blood flow will not be proper. Therefore, in a normal carotid ultrasound examination, the color velocity scale should be 30 to 40 centimeter per second, that is taken as the mean velocity. Now, what are the color gain controls? The color gain should be set so that the color just reaches the intimal surface of the vessels. If the color gain setting is too low, trickle flow may go undetected. If a color gain setting is high, bleeding of the color, that is the bleeding of the color into the wall and surrounding tissues, will limit visualization of the plaque surface and give us a furious reading. Now, sample volume gate and the angle correction are the another few things. If the Doppler angle is small and is more than 60 degrees, small error in estimated velocity may occur. Preferred angle of incidence is 45 degrees plus or minus 4. The optimal position of the sample volume gate in a normal artery is in the mid lumen parallel to the vessel wall in dissected in deceased vessel, parallel to the direction of the blood flow. Now again I'll repeat, the optimal position of the sample volume gate in a normal artery is in the mid lumen parallel to the vessel of a deceased vessel, parallel to the direction of the blood flow. So that gives you the correct readings. Should not be placed on the sharp curves of a tortuous artery, which will give a false high velocity readings and therefore it will mislead us. Now, should not be placed too close to the vessel wall, then the spectral broadening will occur. Now, what is spectral broadening? Spectral broadening results from turbulence in the blood flow. Now, what are the causes of spectral broadening? A large Doppler angle can cause it. A sample volume gate located close to the vessel wall can result it. A high Doppler gain settings. The size of the gate is normally between 2 to 3 millimeters. Too small, 1.5 millimeter gate, the Doppler signal may be missed. And if it is too large, that is more than 3.5 millimeter, spectral broadening will occur. So you will have to set it in proper setting so that you will get a proper spectrum. To avoid excess pressure on the carotid bifurcation is necessary. Now, why it should be avoided? Because it can stimulate carotid sinus, which can cause bradycardia, syncope, ventricular systole, compression of the carotid arteries may result in high velocity values. So that will mislead us. So that is why a high pressure on the carotid bifurcation should be avoided. Otherwise, we'll land with all these problems. Now, what are the limitations? Short muscular neck A high carotid bifurcation, tortuous vessels, and calcified shadowing plaques can cause a limitation to the examination. Now comes a selection of transducer. High frequency linear transducer, that is more than 7 MHz, are ideal for assessment of intima media thickness and plaque morphology. Lower frequency linear transducer, that is lower frequency linear transducers, are preferred for Doppler examination. Now, in a short muscular neck, if imaging with a linear transducer is impossible, a curved array transducer is of very handy and is useful, but the frequency has to be more than 7 megahertz. So that can use the or that can serve the purpose. Now, color Doppler sample window. It is also essential to have a proper color Doppler sample window. It is also known as color box. The size is adjacent to incident. The size is adjacent include all regions of interest. So color box should include all the area of interest adjacent to the angle. By changing the box angle from the left to the center or the right, the things can be achieved. Angling the transducer to ensure that the Doppler angle is less than 60 to the direction of the blood flow should be achieved. Now, what are the standard Doppler spectral examinations? This includes common carotid artery, proximal and distal segments, then carotid bulb, internal carotid artery, proximal, middle and distal segments, and external carotid artery. Only the proximal segment is a part of this examination or included in carotid artery examination. Now, what are the carotid artery diseases? Are the atherosclerotic changes, non-atherosclerotic changes which can cause pathology in the vessel wall, that is the fibromuscular dysplasias, dissections, vasospasm, aneurysm, pseudoaneurysms, AV fistulas, arteritis, and carotid body tumors, to add few. Now, let's go to the technique of the Doppler. First is patient's position. There are two methods described. I will state here the method used by us. Now, this is a part 2 of the same carotid series. We are going to the slide starting from the patient's preparation. Now, we are going to part now. The technique of carotid Doppler. Patient's position. There are two methods described. I will state here the method used by us. In our method, patient is supine or in sitting position. The examiner uses the right hand for both carotid arteries. This position makes it easy to simultaneously control the machine as well as probe positions. It is also described as doing the study by both the hand by sitting on either side of patients. However, since we are not doing it, we have no experience of this technique. Now, the technique of performing carotid Doppler. A pillow is not necessary below the shoulder. Sometimes if the neck is short, if the patient has got difficulty in extending, then the pillow is necessary. So option of the pillow depends on the patient's neck position. However, it can be used as a routine also. The patient's head position is tilted about 45 degrees away from the artery being examined. That is the second thing. Third, the neck of the patient should be relaxed to obtain optimal penetration and angulation of the probe. To perform study adequately, sternocleidomastoid muscle should not be in a contracted stage, it should be in a relaxed stage. Now, further continuing the technique, the right carotid artery arises from the right brachiocephalic trunk and its proximal segment is seen in most of the cases. So that is the first thing we start, and we start there and we examine that. The left common carotid artery arises from the aortic arch. Sonography cannot show the proximal segment of the left common carotid artery, so it may be skipped. The examiner should be able to differentiate the internal carotid artery from the external carotid artery and there are techniques which we are going to say or going to state and going to show you as the slideshow goes ahead. Now, how to differentiate the internal carotid arteries from the external carotid arteries? The internal carotid artery is located posterior and lateral to the external carotid artery. The internal carotid artery is slightly larger than that of the external carotid artery. The external carotid artery has branches such as lingual artery, but the internal carotid does not branch in the area we are seeing. The Doppler spectrum from the internal carotid artery show a lower resistive pattern. The resistive pattern of internal carotid is of low type. The velocity differences between the systole phase and the diastole phase of the ICA is smaller than that of the external carotid artery. Now, how to differentiate internal and external carotid arteries? Uh, the technique is as follows. Place the fingertip on the ipsilateral temporal bone. Give a gentle tap. This will produce a serration-like artifact on the Doppler spectrum if it is external carotid artery. This temporal artery tapping produced or induced artifact is not seen from the internal carotid arteries. So this is called as a temporal tap. Now we'll go to the pathologies of the carotid arteries. First is intimal thickness. It is essential to know what are the layers of the carotid artery. The inside is the intima, that is the innermost layer of the carotid artery is called as intima, then comes media, and then comes adventitia. Now these are the three layers of the carotid artery. The normal values for intima media complex is 0.8 millimeter. Now intima media thickness, let us go to the more detail of intima media thickness. The measurement is used as one of the parameters of atherosclerosis. The intima media thickness, let us call it IMT in subsequent portion, is measured on a two-dimensional 2D grayscale imaging. It do not require any color Doppler. Longitudinal scan of the carotid artery is obtained. Then the center of the carotid artery, two bright interfaces are identified along the arterial wall. In the far wall, the upper bright line is the interface between the blood and the intima, and the lower bright line is the interface between the media layer and the adventitia layer. The interface between the intima and media does not produce any interface. Measurement of the thickness. The distance between the upper and the lower bright line represent the thickness of the intima and media layer. For precise values, the carotid artery should be parallel to the probe surface to minimize the overestimation of the IMT, that is the thickness, from the diagonal measurements. The IMT is generally measured on common carotid artery. Now, measurement of the intima media thickness. It should be measured on a segment without a focal lesion. Focal atherosclerotic lesions are much more common in internal carotid arteries than on common carotid artery. Many vendors provide a automated tool for measurement of IMT. Carotid artery atherosclerosis as measured by the IMT is an important risk factor for stroke and myocardial infarction. So in these patients, they need it. Now let us go to the individual pathologies. First is plaque. Now the risks caused by the plaque. The ulceration of plaque is a strong predictor of the future embolic event. Color Doppler ultrasound and pulse Doppler ultrasonography are ideal for detecting carotid artery stenosis. The precise diagnosis without error For precise diagnosis without error, sonographers should be familiar with the physics and other parameters of the Doppler. Now, what is a plaque morphology? First is plaque volume. The plaque morphology such as echogenicity of the plaque, the surface presence of ulceration, as well as presence of the plaque causing stenosis. It is important for predicting future cardiovascular events. Now, plaque ulceration. Ultrasound features suggestive of plaque ulcerations are focal depression or break in the plaque surface, then anechoic region within plaque extending to the vessel lumen, and eddies of the color within the plaque. Now, texture of the carotid plaques. They are homogeneous. If they are homogeneous, they are stable, homogeneous, uniform echo pattern with smooth surface. That is acoustic impedance similar to that of the blood are the second type. Third are the heterogeneous plaques. They are unstable. So they are important from stroke point of view. Then mixture of the high, medium and low level echoes with smooth irregular surface are having more risk. Now the diagram shows first are the calcified, then homogeneous, second is the iso-echogenic, third are the low echogenic, are the three type of plaque which are shown in the diagram. Carotid plaque reporting points. What we should keep in mind when we are reporting a carotid plaque. These are identified as a local protrusion of the wall into the lumen with areas 50% greater than the intima media thickness of the neighboring sites. Parameters and properties of the plaque are again and again important. We are repeating and we are emphasizing. Plaque extent, location, size, including the maximum thickness area and the elevated areas are to be known. Then texture, surface, morphology, mobility and luminal stenosis it causes are also to be known. Now, carotid artery plaque reporting. What should come in the reporting? One is echogenicity. Echogenic plaque, isoechogenic plaque, then echolucent or heterogeneous should be reported as per the appearance that on the Doppler study. Then presence of ulceration are important. Plaque ulceration is associated with increased risk of stroke, and the surface of the plaque, whether they are smooth or irregular, again needs to be reported. Now, the total plaque volume can be measured by three-dimensional ultrasonography. The plaque counter is pressed manually and then the volume of the plaque is calculated. Now, if the plaque surface is more than 2 millimeters, they are important. So, plaque surface more than 2 millimeter, then it is thought to indicate ulcerations even if we do not see them on studies. The pattern of plaque ulceration can be a cystic, that it can just look as a cyst, it can a bridge in a shape, it can be sponge-like, or it can be simple depression. So these are the appearances of the plaque ulcerations. The plaque echogenicity, the hypoechoic are more symptomatic. Then what constitutes the plaque? The plaques are constituted as follows. If the plaques are of low echogenicity, they have got lipid. If the plaque are the moderate echogenic, they got collagen. And if the plaque has got high echogenicity, they contain calcium. Now, these are the detection of constituency or constituents of the plaque from the sonography. Now, heterogeneous plaques are calcifications. There are calcification, then they can be focal hypoechoic, they indicate hemorrhage or necrosis, and plaque surface features also include common surface of the cerebral emboli. Now, pathologies of the carotid artery. We are studying the same topic today. So, in this context, now we are seeing the technique and waveform analysis of the internal carotid. The basic interest here is to analyze the internal carotid artery waveforms. Now, internal artery spectrum findings, if it is absent or if it is absent or it is occluded, then echogenic intimal flock or with or without thrombosis, then hypoechoic thrombosis with or without luminal narrowing, and high resistant waveforms and dampened flow, narrow appearance of the common carotid are the few of the findings we must know when we are reporting the internal carotid dissections. or if we find all these things, absent flow, echogenic intermittent flop, hypoechoic thrombus, high resistance waveform, diapent flow, or normal, could be normal, then you can suspect carotid artery dissection. Now second is the stenosis, whether it is internal carotid or common carotid. Peak systolic value PSV greater than 230 indicate that there is a severe stenosis. A large plaque, 50% lumen diameter reduction, can indicate there is a severe narrowing and stenosis. Then color aliasing, then spectral broadening, then post-stenotic turbulence, then Power Doppler imaging, the color buoy artifacts in the surrounding tissues of the stenotic artery, then end diastolic velocity or greater than 100 cm per second. They are again indicative of the severe stenosis. Then internal carotid, common carotid, the peak systolic value. If we calculate the peak systolic value and the ratio, and if it is 4 or greater, then again it indicates that there is a severe stenosis of internal carotid. A high pitch sound at Power Doppler imaging also indicate a stenosis. First we are seeing dissection, now we are seeing stenosis, and now we are seeing the focal stenosis of common carotid. The ratio of the highest PSV at the common carotid artery stenosis divided by peak systolic value 2 cm proximal to the stenosis should be calculated. Peak systolic value of common carotid at stenosis, peak systolic value of common carotid proximally. If the ratio is 2 or more than 2.99, stenosis of more than 50% is suspected. And if the ratio is 3 or more, stenosis of 75% or more is expected. Now all these things are required when we are reporting how much stenosis is there in terms of percentage in our report, and therefore they are very important. Now what are the causes of unilateral low peak systolic volume? One is proximal stenosis, that is in brachiocephalic, then parvus stardust waveform or normal wave pattern, asymmetrical peak systolic values, distal stenosis, carotid bulb level. If there are difference in the peak systolic values, then we have to think will give high resistance waveform. If it is unilateral low peak systolic volume, then we have to consider all these parameters. When we call abnormal common carotid artery either low or high peak systolic volume, then abnormal high resistive waveforms and abnormal low resistant waveform are the causes. Now what causes abnormally low PSVs? A normal common carotid and the peak systolic volume should be in the range of approximately 60 to 100 centimeter. Any common carotid artery, when we estimate the PSVs, they are in the range of 60 to 100. If it is less than this, examination should be done for opposite side also, that is for the comparison. It should be noted whether it is symptomatic or asymptomatic. Now that is a clinical correlation. Velocity difference of more than 20 between the right and left side is abnormal. So go for the difference in peak systolic values. Now let us come to the pathologies of common carotid arteries, that is of the disease walls. Now Doppler criteria for diagnostic of internal carotid artery stenosis. There are certain criteria we'll look into. Now the diameter stenosis is the first table. Second is the peak systolic volume. Second, end diastolic volume. Third, and a ratio of internal carotid and common carotid is the last one. Now you can go through it. What happens if it is normal? Then less than 50%, 50 to 70%, and more than 70%. Near total occlusion, the criteria is also given, and total occlusion, if it is undetectable, then also it is given in the chart. Now, are there any other parameters to grade stenosis of the carotid artery? Yes, they are peak systolic velocity. Then best documented Doppler parameter for carotid artery as on today is again peak systolic velocity. Then end diastolic velocity, quite valuable for detecting high-grade carotid stenosis, are the peak systolic value ratios. And to avoid errors of the collateralization, these things should be calculated, and to avoid errors of physiological factors. The blood pressure, pulse rate, cardiac output, peripheral resistance, all things needs to be considered. So self-examining diagram of stenosis, readings taken, proximal at stenosis and distal, and their significance. Now surface of the ulcer. What can happen, or what are the possibilities of error in diagnosis? That image plane not included. Then adjacent plaque simulate ulceration. Plaque surface irregular but not ulcerated. Now, is there any relation between the diameter reduction and cross section of the area given? Now, the first table gives a diameter reduction and second gives the cross sectional reduction. Now, these will give you a real Doppler picture of the pathologies. So what can cause carotid artery diseases are atherosclerotic diseases, non-atherosclerotic diseases, fibromuscular dysplasias, dissections, vasospasm, aneurysm, pseudoaneurysms, arteriovenous fissulas, idiopathic carotidinea. Now all these things we have seen already before. Now this was just to recollect what we have seen and just to summarize it. Now this is the circulation. Again, it is just to recollect. Now this is again what we have already seen, temporal tapping and sawtooth appearance, that how it occurs when we tap on the temporal region and get changes in the arterial waveform. So this is the technique of temporal tapping, and this is the result which is shown. Now we are finding a diastolic notch in the picture. Now what causes it? It is the closure of aortic wall with temporary cessation of forward flow and then resumption of the forward flow by elastic rebounds of the aortic wall. So it is these mechanism which causes this notch. Now often the question comes is the how to differentiate internal carotid and external carotid. Now we are going to a repetition just to summarize, or we can call this as a summarization or just to recollect. Now what are the features of the internal carotid and external carotid are the size, branches, orientation, then pulse Doppler findings and the temporal tap. So this is just a recollection of what we have seen and summary of our today's lecture. Now pathologies of the carotid artery, with continuing now. Here we are showing you how the patterns looks like. Now, a typical normal Doppler spectrum. The internal carotid artery is the top, then external carotid, and then the common carotid. Initially we are seeing theoretically, now we are seeing practically. Now variation in extracranial circulation, left common carotid and subclavian arteries share a single trunk. Left vertebral artery arises directly from the aortic arch and right vertebral originate arising from the aortic arch. Now these are the variation in extracranial circulation which we see on occasions. Now this will help you for interpretation. Percentage wise, if more less than 50% stenosis, PSV you will get is 125. If it is 50 to 80, you will get PSV 125 and above. If it 80 to 99% stenosis, you will get 140 and above. And if it is more than 70, internal carotid ratios will be more than 4. And if there is occlusion, there will be complete block of flow. This is just a recollection of what we have seen and memorizing, summarizing the interpretation points, and this needs to be reported in the films. Now, carotid duplex ultrasound. Now here, the degree of stenosis is determined by the velocity of the blood flow. Here the velocity, the greater is the stenosis. Again, this is a description of the diagram which you are showing and interpretation. Now, intima media thickness complex is normally 0.8. Now here again we are showing the walls of the carotid arteries and their thicknesses. Now, carotid dissection. Usually trauma like seat belt injuries or repetitive traumas may be occurring because of the blows or because of the occupation, then this can be seen. Occasionally spontaneous and isolated to the carotid arteries in Marfan syndrome, and there are certain fibromuscular dysplasia and other diseases which we have enumerated. Also, direct extension of an aortic dissection can continue in carotid. Then rare but dissection of the intercarotid artery is the most common cause or most common use of the stroke in young patient. Though rare, in young patient, this should be thought of. Most intercarotid artery dissections occur in the level of carotid bifurcation. Now, we have seen first is the anatomical aspect, then was the technical aspect, then was the Doppler technique, how to perform, what are the methods, then the pathologies, which are the pathologies which are detected by carotid Doppler. Then we came to the some ratios, some useful hints for reporting, and with all these things we are sure that we will make some understanding of the carotid arteries, when it is to be done, how it is to be done, how to avoid the errors. Now, why all these things is carotid Doppler is getting more and more importance since it is easily available. Most of the hospitals has got it, can be shifted to bedside or in operation theater. They're reliable, easily available, non-invasive, radiation-free, and economical. These are all advantages of ultrasound which are shared by the Doppler. Within its limitation, it is the first investigation of choice in the carotid vascular diseases in the patient of stroke or when you are suspected any intracranial pathology. It has almost 70% sensitivity when compared to the angiography. With this, we are coming to the end of this lecture. At onset, I've given you the idea about the lecture, its limitations, and now I am saying that I am thankful for giving me your valuable time, which is most important for me. I had tried in my own efforts how to give good idea about carotid. Please note, radiology is not a race. It's a process. Be a part of this process and enjoy the feast of knowledge. I am Dr. Anil Joshi, logging off. Till we meet again. Thank you. Take care. Do your best to benefit patients.